This is Wellness by Design, and I'm your host, Andrew Whitfield Cook. Joining us today is Alexandra Middleton, a naturopathic nutritionist, who's going to be taking us through a patient-practitioner hybrid of managing endometriosis with dietary and environment modifications. Welcome to Wellness by Designs. Alex, how are you?
I'm good. How are you going, Andrew?
Really good, thank you. Now, you've got a lot of experience, but first take us through a little bit of your history, maybe pertaining to endometriosis, when you first started to notice symptoms up to diagnosis.
Well, first of all, I developed a heavy period when I was 14, but didn't really know I had an issue until I started to get pain around the age of 20. And after seeing 3 different specialists, the last who told me it was in my head, I found a 4th who believed me, and I had my first laparoscopy, and I was diagnosed with stage 2 endo at the age of 21. So that's how I've been diagnosed with endo, and I'm 41 now, and it's been a lifelong journey for me trying to figure out how to manage it. And through natural medicine, I did discover that you can't cure it, but you can definitely reduce symptoms with the use of food and natural medicines, etc.
This is really concerning how medical practitioners, and it does still happen. I've spoken to somebody just the other day who said that's a condition that doesn't really exist.
Yeah, it is still
This is
going
in this
on.
day and age.
Yeah, that's right. I mean, I see probably, 10 women a week with endo, and they're either getting dismissed, their symptoms are getting dismissed, or they're getting missed completely. I probably see more women with undiagnosed endo that consequently then go ahead with doctors to get diagnosed with the right doctors versus seeing women who are already been diagnosed with endo. And when you think about, I can't remember the most recent statistics, but 1 in 8 or 1 in 10 Australian women have diagnosed endo, which means they've had to have a laparoscopy to be formally diagnosed. To me, that's terrifying in terms of how many more women might actually have it. So it's definitely a disease of this century. I have my theories as to why. But yeah, the doctors not diagnosing it is a problem. I actually think it comes more down to education. A lot of the GPs, they're so busy. Generally, they get 15 minutes with a patient, and their education space is their lunch break, where usually they're seeing pharmaceutical reps versus health practitioners who have a bit more of an integrated approach and are maybe a bit more on top of the research. But I found that, doctors are open to learning more and to being guided as to how to look for symptoms, and also, other things like blood markers and things that they might not know about that can potentially indicate endo or other, issues that involve reproductive inflammation, etc.
Yeah, I guess, when you say the word missed, I can accept that because it's quite a difficult disorder to detect, and that's why there's such a delay in diagnosis from symptomatology. But dismissed, that's not really applicable or appropriate for any healthcare practitioner to dismiss somebody's claims of concern. So I take your point though about education. I remember an education series. It occurred over several weekends, and it was in Sydney. I think Jason Abbott spoke at it, Leah Heckman. There was a few other people that spoke there. Is that correct?
Yeah, you're talking about the symposium in 2017, the endometriosis.
Wasn't the ATMS symposium? It was a seminar series held in Alexandria, I think it was.
At the IVF hospital.
Was that it?
Yeah, that was in 2000. Don't quote me. I think it was in 2019. Yeah, that's right. Gavin Sachs and Annie Forth. Yeah, led it. Right. Yeah.
Gotcha. But that was very well attended by GPs and holistic practitioners alike, correct?
I don't know if you'd say well attended. I was in the room. There were maybe 30 or 40 people in the room. at least half of that were complementary health practitioners. And frankly, I was at 2 of the talks, but some of the doctors in the room were very resistant to some of the new information that was being presented to them. And there was one particular doctor that got up and actually tried to argue with one of the practitioners who was seated up talking about the research. So I wouldn't say a lot, but there were some, yeah. That's also an integrative flow at that hospital. So it's the audience they do pitch at. Yeah.
Gotcha. I see. So tell us more, though, about when your approach to endometriosis changed. You said that, it's changed dramatically once you'd embraced holistic practices. But what was the initial journey and treatment? And then what changed along the way for you?
Well, I think the first step was that I realized I was working in corporate, realized that working with diet helped me reduce my symptoms. Looking back now, it's kind of, I laugh because I was nowhere near where I needed to be. And on the back of that, when the market tanked in financial services, I left to study nutrition at Nature Care. And it was really through my diploma at Nature Care that I started to, especially in the second and third year, these light bulb moments of how not just food, but especially environmental stresses can actually impact endo symptoms. And, even I remember the big turning point was I was writing a paper on heavy metals and how that can contribute to different reproductive issues. And so I thought, I've got 6 amalgam fillings in my mouth. I wonder if that has anything to do with my symptoms, and took myself off to an integrative doctor, Dr. Emmanuel Veripatis, and realized that I had pretty severe mercury poisoning. And when I addressed that, when I was still studying, a lot of my symptoms got a lot better. I had a terrible chronic fatigue for most of my 20s. That significantly improved. I dropped 10 kilos without doing anything with my diet. Things started to radically shift. So learning about how to detox properly and how to, work with food to manage my symptoms when I was studying was a very big pivot point for me. The other thing I mentioned is that after my first laparoscopy, the endo was there, but I didn't really struggle with it. Even during my time at Nature Care, I didn't struggle with it. But when I moved into a house in 2014 in Paddington in Sydney, and I suddenly crashed, had my very first, I used to call them endometriosis attacks. Most women call them flares. It was so bad that I was visiting a client and the client had to call an ambulance and I had to go to hospital. And that was definitely not a once off for me with these endo flares. And so at that was another pivoting point, learning how things in the house could totally trigger me. I've since learned that I was definitely mold. And so one of the first things I'm always looking at with the women I see with endo is, are they living in a water damaged building? Do they have mycotoxin exposure? Do they have any other sort of chemical sensitivity in the house that could be driving their symptoms as well? So that was a big turning point too.
When we're talking about these multifactorial issues affecting one condition, you speak about stress, and then you talk about mold. So there's an immune assault. You talk about environmental issues, other pollutants, things like that. So obviously there's got to be a detective hat there about how wide do you spread that net to look at heavy metals? Do you look at, mold, emotional stress, psychological stress, blah, blah. Do you look at all of these at intake? And do you go through everything first? Like, that's a lot of work.
Listen, women with endo usually don't just have endo. They've usually got a whole lot of different comorbidities that go with it. The ones I most often see, obviously gut issues. Usually there's a parasite or some sort of bacterial overload, which is driving LPS in the gut, and then consequentially creating more inflammation in the peritoneal cavity. Thyroid issues are also common. Food intolerances are super common. The mold issue is super common, especially on the east coast of Australia. Mycotoxins, which are the poisons that the mold spores breathe out, they drive aromatase in the liver, and that in itself can then drive estrogen, which can then make endo worse. So yeah, it's like I say to my clients, I've got a big questionnaire that they fill out before they come to see me, but what I tell them is, look, it's not just going to be one thing. It's like unpeeling an onion, and we've just got to tick things off the list. And it's everything from big infections, the endo itself, looking for things in the blood work or stool analysis or whatever it is that might have been missed. Working with food, you know, what are they sensitive to, what will they do better off, etc. There's a very big long list, and it even goes all the way down to like small things in their house. So for example, you know, are they using scented toilet paper, and is it upsetting the vagina microbiome, which could potentially then cause issues? Could they be using toxic house cleaning products? You know, are they dry cleaning their clothes with stuff, chemicals that are toxic? There's a huge list. It's so big. I've got 4 pages of it that I send as a tick list now to my clients. So yeah, it is really multifaceted, and it's too much for me to help them on their own. I'm really big on referring. I passionately believe that you get the best outcome for the client if you work with other practitioners, especially medical practitioners, which I think in our profession not enough practitioners are doing, maybe because they don't know how, they haven't got the confidence. I'm lucky enough to have come from a family of doctors, so I kind of know how to talk to them. But working with the different doctors, whether it's a G, and with endo women usually, you know, it's a GP, an endocrinologist, an excision specialist / surgeon / gynecologist. The person I probably work with the most is a functional gastroenterologist, because sometimes herbal medicine doesn't work for gut bugs, etc. And so like pulling together a team for the woman who has endo and probably a list of other things is actually how you get the ultimate outcome for her. So I'm big on that.
Right. You mentioned that you discovered early on that dietary modification eased your symptoms. So we'll go down that path. But before we do, you just mentioned a gastroenterologist. So do you find that there might be a place for fecal microbiota transplant in endometriosis? I know that sounds like a big job for, I mean, it's almost glib to say this, a seemingly lesser condition rather than, you know, something fulminant like Crohn's. But endometriosis is much more serious than just pelvic pain and a little bit of tiredness. There are people who have lost bladders. There's, you know, horrible surgeries that women have to go through because of endo. So it's not a trivial disease at all. So
yeah,
FMTs, do you think there might be a place?
Personally, I'm not big on FMT, especially in Australia. The way the samples are taken from donors and screened isn't optimal. It's certainly not to the standards of those in America. And, you know, there are quite a few studies on all the other things you absorb from someone, from an organ transplant, or even just a fecal transplant, including bugs. Who knows how well that person has taken care of themselves, and if everything's not being screened for, you don't know what you're taking on from the other person. So I'm not sure about FMT. I do think there's a place for specific antibiotics, particularly, you know, in the presence of a nasty parasite like blastocystis. I know a lot of my colleagues don't agree with me, but for me, it's all about, you know, getting the quality of life back as quickly as possible for the client, A, so they can have a life, but B, also so they get more invested into continuing to work on everything else that could potentially driving all of their symptoms. And, you know, antibiotics aren't ideal, but sometimes they're required. And they can, if they're managed properly and the supportive work with probiotics and all the other gut restorative stuff is actually done well, it can give them a good quick fix to get a better quality of life. Also, if it is something like a parasite, you've also got to measure up, well, you know, the herbal medicine might not be doing the job. You know, the parasite might go away for a year and then come back. And in the meanwhile, the parasite's leaching things like endotoxins and continuing, like LPS, to contribute to inflammation in the peritoneal cavity. So what's better? Potentially injuring the microbiome, but also getting rid of that bug, but then doing the repair work. To me, that is better for most people. You always want to try the natural road first, but there is a place for that for some people, and it does help.
Yeah, sure.
Also, a lot of endo symptoms go away with antibiotics, which is very interesting.
Wow. Okay. So is this because of a suspected parasitic organism or other organism? Like, how have the antibiotics been prescribed?
I think it depends on the antibiotic and what. So it's multifaceted. If we're talking about a parasite, you're eradicating any potential inflammation that the parasite might be causing. So they might get relief that way. But more importantly, you know, there's that hypothesis that, you know, one of the many, that underlying endometriosis is bacterial contamination, where LPS basically translocates from the gut into the peritoneal cavity and thus inflames things. So it could be working by that road as well. I've seen a lot of women on doxycycline feel a lot better too. Interesting, a lot of people, as a side note, women that have, you know, SEERs or mycotoxin issues also feel better on long-term doxycycline. So yeah, it's a bug thing, you know, you lower the bugs. And that was probably the other very big shift that I didn't mention before was, you know, I was a patient of Leah Heckman's the last 3 or 4 years, learning about the different microbiomes of the body, the sinus microbiome, the microbiome of the mouth, the gut, the vagina, you know, the uterine cavity, etc., and how all of those microbiomes work together to impact health generally, but especially reproductive health. And you have to clean those microbiomes up and get them working optimally to reduce symptoms. Absolutely.
So when you're talking about these various microbiomes, though, or microbiota populations, are we talking about really, in the end, managing, forgive me, you spoke about LPS. So are we really talking about managing inflammation? So do you measure inflammation as a general marker to see if the microbiota, let's say probiotics or foods that you're giving these women is actually having an effect on their inflammatory status? How do you tell that they're getting better? Symptomatology?
Yeah, to be honest, the main way I tell them, figure out if it's improving, is ask them about their symptoms. That's the main way.
Gotcha.
Yeah, the severity of their symptoms in particular, because a lot of women with endo, the symptoms won't go away completely. They can do all the right things and it'd be 80-90% better, but it's still kind of humming away in the background.
Yeah, which is like that's dramatic improvement, but you're right. Like, unfortunately, there's just no cure. Now we have to go into food and dietary modification, because indeed you've written a paper on this now, haven't you?
I have with the boys over at National Institute of Complementary Medicine. Thanks for mentioning.
Hi, Dr. Mike Armour. How are you? You've got a funny accent. Tell us about your paper.
Okay, so constantly talking about how diet, you know, can radically help women with endometriosis to Mike and Justin Sinclair and stuff over at NICM. They had already completed a survey of 590 women where they asked these women about generally the different ways in which, you know, food might impact their symptoms. And what they wanted to do was just to see if there are any common themes in the survey results. And so what they found is that 80% of women did use diet to manage their symptoms, mainly by cutting out dairy and FODMAPs and gluten. And the main benefits, well, the biggest main benefit was a reduction in endo-associated GI symptoms, like IBS symptoms, for example. Also improvements in pain scores and some in fatigue. And so the NICM team had completed the survey and we got together to write it all up. And what we wanted to do was correlate the themes in the paper with pre-existing studies, which was my role. And I was trying to figure out the ways in which these, you know, FODMAPs, gluten, dairy could actually potentially, from a mechanism point of view, be reducing symptoms. So, for example, you know, the casein in dairy foods and how that can be inflammatory by nature, and how the histamine component of dairy foods could potentially drive estrogen, which can then, you know, also go on to fuel endo. things. The way FODMAPs can be inflammatory in the gut and can make endo worse in that respect. So I wrote the discussion piece, and it was really interesting. It was also particularly on the histamine side. It was really nice to be able to write something about how high histamine foods or amine foods do drive symptoms of endo, because no one's really written about it yet. And it's definitely not in any of the formal guidelines recommended. And I mean, a lot of the formal guidelines are still recommending dairy for endo. And so, yeah, that was the short of the paper. And I'm now trying to convince them to do another one.
Yeah, good on you. That's great. So that's very interesting to me as well with the histamine approach, because we know about biologically active amines with, say, migraineurs. That's been quite accepted for decades, and allergy clinics will work with these patients on monitoring that for their migraines. But now we're talking about a condition at the other end of the body. And so is there resistance to accepting that these biologically active amines may have an effect on, I mean, what is it? Is that inflammation again, or is that some other mechanism? Like, I'm trying to think here.
No, it's not a resistance. It's the problem. There's just not enough evidence directly correlating symptoms of endometriosis with histamine foods, or even the histamine process in the body generally. There is quite a bit of evidence showing how, histamine, if you eat something, an amine-rich food that's rich in histamine, or a food that liberates histamine in the body, that can then stimulate mast cells to release, it can stimulate estrogen, and then estrogen can then stimulate Pareto cells to release more histamine, and then it goes on like a chicken and egg circle. And so a lot of women can get relief from histamine kind of symptoms, but also from estrogen type symptoms by cutting out foods that are either rich in histamine or that liberate histamine, biological amines. But yeah, there's no papers directly correlating each. Maybe I'll write the first, hopefully. Never know. You hear that, Mark Mymore. But yeah, and I was kind of excited to mention, I did write a little bit about that in the paper when I was talking about dairy, because it's for me with clients, I mean, cutting out gluten is great because you definitely decrease inflammation, and a lot of women have issues with gluten and wheat. Cutting out dairy, particular cow dairy, is also great for similar reasons. But in my experience, personal and with my clients, the biggest relief you get is by cutting out histamine-rich food, and especially it's especially important since the mainstream media is constantly promoting, probiotic foods, for example, fermented foods to everyone for good gut health. Well, they're not actually good for everybody, especially women with endo. They can make them a lot worse. So yeah, I hope there will be more written.
Yeah. So, I mean, that it's one of these things where we go into these cycles of what's good and bad, and like fermented foods are all good. Yeah. I've still got concerns about nitrosamines in fermented foods, and what that plays. But anyway, we get off track. We need to go a little bit further into, you and I have discussed frank nutrient deficiencies that you've seen in endometriosis, things like iron. So how do you assess and address iron deficiency in endometriosis?
Well, the first way I assess it is through blood work. Pretty much for every single one of my clients, whether they have endo or not, I'm referring them to a GP for the full blood work of everything. And I write that letter. I try to refer them to people who I work with. Just a standard iron panel that goes through the iron, ferritin, saturation, transferrin, etc. And I have a look at that. I do sometimes have question marks about the ranges of iron and if that's outdated yet. But, and women with endo typically are anemic. And it's really hard because, iron can flare symptoms of endo in women that are sensitive to it. I can't tell you how many people I've seen, me included once actually, I didn't know till after the fact, that, they've got endo, they're having heavy bleeds, they're probably not eating enough iron-rich foods. The stomach acid isn't working very well, so they're not absorbing it very well. And the GP says, oh, you're anemic, and sends them off for an iron infusion. And then within 48 hours, they're at the hospital because they've had a severe flare. And what's happened is the infusion has just completely flared things up, because iron by nature is an oxidant. It will inflame things that are already inflamed. And this is all also in the literature. It definitely feeds bugs. And there's a couple of different really interesting papers that have talked about how endo is simultaneously a disease of iron deficiency and iron overload. Because what happens with women with endo, because of a funky immune dysfunction that's to do with macrophages, is that, you know, they take iron in and they store deposits of it within these endometriosis lesions, in the peritoneal cavity mainly. And so what happens is these women actually start to accumulate and build up their iron in these lesions, but they're not actually able to access it for things like transporting oxygen around the body, etc. And so they have symptoms of anemia. And what happens is the iron accumulation eventually can hit a toxicity level, and then that can actually fuel more development of endo, so I've read. So it is in the literature. I mainly see it with my more sensitive clients. You know, there are some times where you've got to give people iron, pregnancy being an obvious one. If someone really needs it, I either give them a chewable, or more often I actually will refer them to a compound pharmacist, and they can get some iron, transdermal iron made up, and they just put a little bit on their wrist at night and try and get it up that way. But a lot of women, once they stop amines and histamine foods and they come off iron for a while and they try to reintroduce it, can actually sense a little bit of a reaction. They might sense a bit of pain, might get a headache, you know, and they realize they can feel the reaction to it. So there are other ways of supporting iron in that respect. Working on diet's a really big one. It's really hard being a vegan if you have endo, because it's really hard to get that iron in. I'm very pro lamb and organic grass-fed animal sources. Working on stomach acid also is obviously a big one. Making sure that protein intake is adequate. That's another really big one. Most women don't eat half the protein they need, or they're not metabolizing it properly. B12 is obviously another supportive way. And then just educating women generally about, you know, iron-rich foods, how to best absorb iron, how you know, other things you can do to help with iron, like cast on cookware, etc. So there are lots of different ways around it. Yeah, but iron supplementation for me with someone with endo is definitely a last resort.
And you spoke about the tests that you send your patients away with or for. So is there anything apart from the standard full iron studies that you do, like, you know, methylmalonic acid or anything like that?
No, well, a lot of the tests that I ask for are actually pretty standard tests, just to get the full, you know, blood work, the, you know, liver panel and everything else. But a couple of things that I ask for, which the doctors aren't so familiar with until I show them evidence for why I'm asking, CA125, which was traditionally a marker for ovarian cancer, is being used by a lot of more progressive gynecologists around town as a marker for reproductive inflammation. So that's definitely one. Yeah, definitely one we use. And the evidence for that is a bit conflicting, but as a rule, if someone's, you know, the range is 0 to 36, and if there's someone who's got, you know, anything over 10, you know something's going on. So CA125 is a really big one. I always measure, you know, a full thyroid panel if I can, because I often see thyroid issues go along with endo. You know, IgG is another really big one. It tells me a lot about their environment, particularly if they're in a water damaged building. So yeah, there's a whole lot. It depends how friendly I am with the doctor, because obviously I don't want it to be expensive either.
Yeah, true. Now, we spoke earlier, you spoke about earlier, about living in a family of medical practitioners and dialoguing. You're quite comfortable with it, but many people aren't. So what can we do to optimize effective dialogue between yourself and the medical community?
I think the first thing I would say is make yourself known to the medical community, which sometimes can be a bit of faking it till you make it. You know, you might want to write an info sheet about how complementary medicines can help women with endo and, you know, hand it out to all your local doctors and stuff. For me, I sometimes still do that actually, but I often just write a letter saying, hey, I saw, you know, Jane and she has this, this and this, and because, you know, this is her family history, this is her personal history, and because of this, would you consider, I never tell a doctor, would you consider potentially ordering this? And most of the time they're agreeable. With the more, like the CA125, which I know a lot of the GPs aren't familiar with, I'll often provide a study. So, and I'll stick it on the end of the letter. So yeah, writing letters, writing emails, making yourself known to them as a person who's working niche with these sorts of clients. Because that helps you get all the testing done under the supervision of a doctor. And as a side note, you know, it gets billed to Medicare, which always helps. But also it really helps with your business. You can get cross referrals and stuff, and you start to work as a team. So I've got, you know, I've got a network of doctors. They send me people, I send them people. We chat on email. Eventually you'll get to chatting on email and stuff, but you have to make yourself known.
To start out. Now, you're not just confident, but competent as well. So you now work within this framework of specialists and things like that. Do you feel confident about saying, look, I'm suspecting this? Would you be amenable to a referral for this practitioner? And so do you actually recommend a certain practitioner or various practitioners who are expert in like laparoscopy, laparoscopic examination was what I wanted to say. Do you confidently ask for that?
Yeah, I do, especially with like certain areas. So for example, you know, sonography, you know, getting a deep pelvic ultrasound, you know, there are a certain number of people in Sydney who do that really well. Ultimately, you can't diagnose through that, but it can, again, if it's good, give you a pretty good idea whether there's endo or fibroid or something sitting there or not. So yeah, I definitely mention particular names. Rarely they'll refer them to someone else. But the thing with medical referrals is, as long as it's, you know, if it's a referral for a gastroenterologist, for example, it can still go to another gastroenterologist and be valid for a year. But the good doctors all know the good doctors. That's my experience in Sydney. So
your trick is to send your patients. Sorry, I cut you off. Say that again.
Yeah, no, that's okay. As I was saying, you never really have to convince them. You can just kind of mention it. In terms of saying, or in terms of your question about, you know, mentioning you might suspect endo, yeah, I say it these days. I probably didn't used to when I first started, but now, you know, it's pretty obvious to me when I meet someone with endo. I don't know what it is, but I mean, the CA125 in the blood work is definitely a marker. The visible symptoms are a marker. You know, the reported symptoms and how they're reacting to things and the environment they're living in, to me, are big signs. And so sometimes you can very often pick what's going to come back. Not all the time, but a lot. So yeah, go on.
But one of the big tricks is to know the good doctors, and obviously, I guess it's a process of elimination for many women. They have to go from those people that don't even believe endometriosis exists to it's all in your mind, to finally somebody that will listen. Unfortunately, they have to make that journey. You can bypass that and just send them to the fantastic GPs who know the fantastic surgeons. So I guess what we need is more papers from you.
Well, papers, but I have to say, like the upside of the endo that I've had and stuff, and I've had a few other health conditions, I make jokes with my clients and like, look, there aren't many medical conditions that I haven't had, so I do know about the doctors. And so I've gotten to know kind of who are the good doctors, which are the good meds, who are open to working with complementary medicine practitioners, which is a big one. And also who are going to listen to their patients, which is probably one of the most important things of all, actually really listen. And there is definitely, you know, a network of doctors like that in Sydney. You've just got to know where to find them. I have a big master list I have worked on over time. I have segregated it by modality, city, suburb, name. I've actually created that with a couple of other practitioners, so it's a pretty big list. So yeah, no, you get to, and you work with other practitioners in your field, like my mates Kate Powell and Lara and Leah, and we all kind of compare notes as well. So yeah.
Yes, and we do need to shout out those people. So Leah Heckman, Lara Bryden, Kate Power. There's so many others, but also Justin Sinclair, Mike Armour at University of Western Sydney. So, is Justin still there? Anyway, we can cover that another time. Yeah, but Alex, thank you so much for taking us through. It's sort of a hybrid podcast because you are deeply involved in this, not just from a caring perspective, but from a self-care perspective. But I thank you so much for taking us through the dietary modifications and how we can help patients with endometriosis today on Wellness by Designs.
Thanks for having me, Andrew.
Always a pleasure. And of course, thank you for joining us today. You can get all of the other podcasts and the show notes for today's podcast on the Designs for Health website. And I look forward to meeting you next time. I'm Andrew Whitfield Cook. This is Wellness by Designs.